Doctor. He graduated from the University of Munich in 1954 with a degree in medicine, an MD degree. He came back to the United States and attended the University of Georgia Law School and was admitted to the Georgia Bar in 1962. He practiced malpractice law. It wasn't until 1978 when he saw a chelation physician in North Carolina by the name of Logan Robertson, who helped chelate him. On his return back to Georgia, Robertson was being attacked by the board in North Carolina. Our speaker went there and proceeded to, on his behalf, and the case was dismissed. Presently, when he's not representing dentists, naturopaths, physicians, and chiropractors in board actions across the country, you could find him in Savannah, Georgia, writing a book called Das kommt wieder, which means that will return. The subject matter is ortho-Nazism in American technology, science, medicine. So with that, let's bring up our speaker.
I guess today I'm supposed to read you a paper about some German technology, which you may not be able to use because before this technology can be safely transferred to this country, we're going to have to get rid of some other German technology that's been transferred here in political science. We're going to have to get rid of Obersturmbannführer von Kessler and his Fedstapo and all of the people that are out to suppress your right to practice dentistry and medicine. Huh?
Speak into the mic.
You hear me better now? Okay. And right now what I'm going to read you is a report from Germany on the way that dentistry is being practiced in Germany without problems, because the Germans got rid of the Nazis. They sent them here. And there's health freedom in Germany, and German physicians and dentists are absolutely free to practice in a very expanded fashion that would be guaranteed to get most of you in trouble if you tried to do it right now. So this is a report about what German dentists are doing in Germany, and not a report at this time about what American dentists are doing in America. But since the subject of this is dentistry of the future, let's hope that in the foreseeable future we'll get rid of the other technology transfer and have freedom returned to America, so you might consider using some of these technologies in your dental practice. In this paper, I will report on the state of biological or probiotic dentistry as it is being practiced in Germany, especially in regard to the evaluation and use of homeopathic formulations prior to treatment, such as using a dental handpiece during restorative procedures, the removal of root canal filled teeth or diseased teeth in general, as well as bony cavitations both pre and post-treatment. Before this is done, a little background information is in order. The physician ought to seek the referral of a probiotic dentist after having had an initial appointment with his or her new patient. It is rare in today's environment that any patient has not had some sort of dental history. It is inconceivable that today's adult patient could escape the ravages of their refined lifestyle and not have some dental complications, especially the patients who present themselves to the physician with a vast array of symptoms that do not fit any disease or symptom syndrome. These dental complications may include the innocuous removal of wisdom teeth or perhaps just a few fillings. Perhaps they have had a root canal or two. Maybe they have had a root tip left in some part of the jawbone. On the other hand, they could have had a few other teeth removed and had some removable bridges or fixed bridges cemented onto their teeth. They might be wearing dentures after having had all their teeth removed. Some teeth may have had a third or fourth generation filling in them. These teeth may be asymptomatic or they may react with pain while eating or drinking. Periodontal disease may be present in various parts of the mouth. The occlusion of the teeth and the position of the mandibular condyles may be out of balance. this would have some effect on the motor and sensory nerves that must transverse through or near the structures associated with the cranial-mandibular complex. Could any of these dental possibilities have an effect on the health of the individual? With the development of cybernetics by Professor Weiner in the 1950s, followed by Prigoghine's theory of thermodynamics in an open energetic system, the foundation for probiotic and biological medicine was being formulated. Prior to these developments, the thinking was that these biological systems of the body were linear, but this is not so. Since the Galilean Revolution of the 1660s, the discipline of medicine approached reality and specific questions about illness with a thinking that was quite linear. It was basically a cause and effect relationship. However, allopathic medicine's big daddy, Rudolf Virchow, in 1862 established his theory of cellular pathology. His theory is based on the premise that every disease is determined by the cells. It is based on morphology. Disease was in the cells, and the process was a localized problem. Increasing knowledge of the ground substance, the basic regulation system, is making it clear that Virchow's traditional view of the cell is an abstraction that is no longer up to date and is dire need of a major paradigm shift. Pischinger and his outstanding collection of scientists at University of Vienna Medical School presented in mass their carefully researched theories on the basic regulation system in 1955, the Congress for the German Society for Focal Research. In essence, they stated that the basic regulation system is the nonspecific sounding board for all stimulants, irritations, and intoxications from the environment, such as live pathogens, chemical substances, and physical influences. The basic system also controls the basic function of life: pH, redox potential, sugar and protein metabolism, oxygen utilization, and regulates and protects the genetic structures. Professor Hartmut Heine, who currently has a research team at the University of Witten in Germany, had his book Matrix and Matrix Regulation translated into English last year. He has further substantiated Pischinger's work. Thus, the allopathic model of cellular pathology needs extreme modification as well as modernization. Its usefulness certainly must be carefully questioned. As a result of the research on the basic system, these processes, acid-base, balance, redox potential, and so forth, are now viewed as being highly cross-linked, and they are subject to a steady state, and we're able to encourage energy and materials within their surroundings. These biological systems have their own dynamics. It begins with an interruption of normal functions. These interruptions are both cybernetic and energetic. Every cell, as well as the mesenchyme, has the address, phone number, and fax number of every other cell, whether it be in the mesenchyme or in a specific tissue or organ. It affects humoral, hormonal, and neuronal regulatory systems before any morphological changes are ever seen in the cells. However, school dentistry and medicine are not taught or practiced that way today. Dentistry and medicine is nearly governed 100% by Virchow's cellular pathology. For example, when a patient arrives at a dentist's office with a complaint or several complaints, one of the first things they do after listening to the patient is take x-rays. The diagnosis and therapy is geared to the elimination of the patient's complaints, but to do so you must find the morphologically altered tissue. The only other aids available to the dentist in searching out a pain problem with a single tooth or several teeth are inspection, palpation, percussion, application of heat or cold in the suspected teeth, or vitality testing. Diagnostic aids available to dentists are very nearly Neanderthal because they are based solely on Virchow's theory of cellular pathology. How many times have you seen or used a pulp tester to check for a painful tooth or teeth in one of the posterior quadrants and found that the patient can't localize and looked at an x-ray that doesn't reveal any widening of the PDM or a break in the lamina dura, nor radiolucency or opacity? If all the others before-mentioned tests are inconclusive as well, you must adjust the occlusion in centric or in the working and balancing excursions. However, if the tooth still hurts and the pulp test value is within range, you as well as the patient are perplexed. Frequent and familiar possibilities are painkillers, antibiotics, or you might instruct the patient not to chew on that side of the mouth or on the tooth for a while. You could scare the hell out of the patient by saying the root canal has to be done if it keeps hurting. How about saying, I guess you're going to have to live with it? Pulp testing is always an iffy proposition at best. When a value is reached that the patient can feel is, if it is within the range of the manufacturer's specification, the dentist says the pulp is still vital. However, the term vital is arbitrary. The pulpal mesenchyme connective tissue in the tooth can exist in varying degrees of inflammation, have varying retrogressive changes taking place in the pulp, or even have a state of necrosis present as proteolytic enzymes attack the very core of the tissue. Semi-vital pulps show clear histological evidence of proteolysis or tissue decompensation that have been extirpated from the teeth that tested in the normal range on the pulp test. This could present enormous problems for both the dentist and the unsuspecting patient. Why? An enormous number of telephone calls are received from patients who want their silver fillings removed. The common comment from this patient usually is, I've heard that silver fillings are not good for you. I want to have them taken out. The office representative must question the patient as to why they want to have this done. They will then respond with a variety of comments such as, I have Epstein-Barr virus and I heard it'll cure that. I've been diagnosed with chronic fatigue and my doctor told me that I need to get the amalgams out of my mouth. I have arthritis. My chiropractor told me to get my fillings out. I've always had allergies. Nobody seems to find out what to do about it. I've heard that I should get my mercury out. I've just been diagnosed with multiple sclerosis. I read somewhere, saw somewhere on television that mercury fillings will cause multiple sclerosis. I'm always anemic, despite anything I do. My friends told me that I should see you about getting my fillings out. The potential for great difficulty for both the patient and the dentist exists. The subject of dental legal matters is not the purpose of this paper in regard to the efficacy of treatment, but rather the efficacy of providing treatment to a specific tooth or teeth. Those above requests, which are heard on a daily basis, are the result of desperate patients who don't feel well and probably haven't felt well for years or decades. They are looking for the proverbial magic bullet. They have seen a dozen or more physicians who have provided countless tests, which at times provided for a diagnosis, but often the results are inconclusive. These patients are frustrated correctly. They are referred to a psychiatrist who tells them, I guess you're going to have to learn to live with it. Many times the mercury silver amalgams have been in place for a decade or more. Some teeth have been refilled a time or two or three. Patients do not even know which ones have been filled a few times or not unless it's a crown. The teeth may look all right and not hurt and are basically comfortable. Then after removal of a fillings and the placement of a new restoration, such as a composite or inlays, onlays, or crowns, heat or cold sensitivity often develops, and this could be long-term. This can and often does lead to an unwanted root canal or tooth removal. The new materials have been tested for compatibility. There isn't a problem there. The occlusion is fine. The contacts are superb. What happens? The dentist gets nervous and the patient is increasingly agitated. A serious situation now exists. It is a rare dentist who has ever done a pulp test. If he has, he will say it was okay when I filled it. I think we should let it sit a little longer. You know, all newly filled teeth hurt at first. This hopefully may be the case, but neither the dentist nor the patient really know, and they are both hopeful that this is the case. If this scenario continues with pain exhibited for a prolonged period, the patient becomes unhappy. An unhappy patient can seek legal or board action. This is the worst case scenario for the dentist. I'm sure a few of you in the audience who may be experiencing palpations now or whose patients or underarms are a little bit moist at the mere mention of this case scenario. The best way to not even get into this sort of predicament, or certainly minimize its occurrence, is to use electrodermal screening prior to developing a specific treatment plan. Dr. Fritz Kramer of Nuremberg developed such a test, which he calls BFD testing. We call it biofunctional regulation. An EAP instrument is used for the evaluation. The acupuncture meridian used to evaluate the individual teeth is the lymph meridian, called LMB, which is located on the medial or radial aspect of each thumb. There are videos available from the American Academy of Biological Dentistry and written materials available on the exact location of performing this test. Members of this group perform these tests on a routine basis in their office and should be helpful. A brief explanation of the evaluation is as follows. The basic value, the Kramer turnaround value, is found using the Palatine tonsil point, LMV 1.1, rather than the classic bowl LMV 1, because the point lends itself well for repeated testing, which is necessary at this point for all the teeth, and it holds up better than the classical LMV 1. Thus, the turnaround number is a most crucial number to obtain because each patient can have different values on either side of the body depending on the condition of their tonsils or lack of tonsils. They may present with chronic or acute problems, degenerative or inflammatory in nature, so using the standard Vol 50 value on the meter is not proper here, as we need to be very specific so as to attest to the regulation capabilities of each individual tooth present or where a tooth once existed when it is stimulated with low levels of current. Once the number is found, then in a systematic manner, the right upper quadrant, or the upper right, lower left, and upper left quadrants are evaluated in order, and a careful chart is kept for each tooth. After careful explanation to the patient, a low-level current is applied by an intraoral probe connected to the EAP instrument. Enough current is applied to the apex of the lower right central incisor so the patient can feel a slight tingling sensation. When the LMV 1.1 point is now tested, the meter may read 68. Then a homeopathic vial of organ preparation mandible D6 is placed into the test plate, which is also connected to the EAP instrument. The test plate already holds a vial of the palatine tonsil, which balance the patient's LMV 1.1 point to the correct turnaround number. In this case, say it is a D4 palatine tonsil, which gives a value of 53. What you want to do is now balance the point to 53 again. Suppose you put a vial of D6 mandible into the testing well, but the reading didn't go to 53, it went to 60. You replace the D6 mandible with a vial of D5, and if the reading should go to 53 when the LMV 1.1 was tested again, you've reached the correct turnaround number. If the original starting number of 53 was not reached, one would continue placing a lower potency of the organ preparation mandible, e.g. D4 or D3, and then multiple vials of D3 until the original turnaround number was reached. The more vials it takes to reach 53, the more stress is present. This means the pulpal and periapical mesenchymal connection tissue is compromised in terms of regulation capabilities. What one is doing is quantifying the amount of stress present. If one vial of D3 balances the point, it is considered a weak stress. If 2 vials would be considered a medium stress and 3 vials would be a strong stress. Then one checks to see if the stress present is the pulp or the periodontium. Nose swords are then used to recheck the degree of degenerative process present. The amount of stress present then determines the regime that one would follow before the teeth are operated on. Before any fillings are removed, the patient's serum has been evaluated from compatibility of all the different classifications of products that may be used. After the compatible products are known, the materials are evaluated with the EAV unit both quantitatively and qualitatively. The latter is extremely important when the patient exhibits a wide variety of allergies to food, environment, factors, and so forth. Any tooth that will be operated on with a dental handpiece for a new or replacement filling that was balanced with either a vial of D5 or D6 exhibits a good regulation tendency. However, the tooth tested at D4, D3, or 2 times D3, the tooth or teeth would be needed to be treated with homeopathic formulations prior to treatment because the pulpal mesenchyme shows regulatory rigidity. If these teeth are treated with a dental handpiece, there's a strong possibility that the pulpal mesenchyme regulatory ability will further decline. This could result in clinical pain in teeth that have never had pain before or a non-vital pulp in due time. Teeth with regulation dysfunction can and do have energetic effects on the bioelectric energy package of a meridian. Previously, it was mentioned that the basic regulatory system is a bioelectrical open energetic system. I'd like to further add that the disturbances of the BRS are regulated by 3 poles. The ground system is connected to the hormonal or humoral pole via the AV anastomosis, capillaries, adrenals, and the pituitary gland. The neural pole is connected via the autonomic mesh of vegetative nerves, parasympathetic and sympathetic plexus, and its subordinates, the hypothalamus and the central nervous system. And the third pole, the cellular arm, is connected via the fibroblasts, the immune cells, and the cells of the reticuloendothelial system. So you can clearly see that the higher regulatory centers can be influenced by changes in the ground system. Thus, if a tooth has a chronic pulpitis or osteitis around it, it can be a source of disturbance to the ground system. And any fluctuation in the ground system will send messages to the higher centers as well as to the rest of the body. A side point here is if you do not yet have the tooth relationship energetics charts for your office that the American Academy of Biological Dentistry is selling, consider buying them, as they very thoroughly and vividly demonstrate these relationships. These teeth are treated in the following manner. First, a sterile multidose dispensing vial, 50 cc's, has been filled with the following formulations: 2 vials of Mucokel, Sonum; 2 vials of Nigersan, Sonum; 2 vials of organ preparation mandible, Walla, D3, 4, 5, and 6; 2 vials of organ preparation maxilla from Walla, again D3, D4, D5, and D6; 2 vials of organ preparation dental pulp, Walla, D3, D4, D5, and D6; and 2 vials of organ preparation dens from Heal, D4 and D200. 1 vial of xyloneural, 5 cc's; 2 vials of pulpitis no-sode, Stalfin, D3, 4, 5, and 6; 2 vials of osteitis no-sode, Stalfin, D3, 4, 5, and 6; 2 vials of Pefrikil, Sonum, D6; 2 vials of Silesia compositium from Walla, and 2 vials of Soniovis from Sonum. If the tooth exhibits regulatory rigidity, it should be treated with the above formulation prior to treatment. This formulation includes no-sodes to cleanse the pulpal mesenchyme, organ preparations to where the no-sodes are primarily directed and support the diseased tissues. Sonum preparations increase circulation and provide a form of symbiotic microorganisms. The Walla preparation supports healing and pain control. Each tooth should have 1/2 cc of the mixture injected into the buccal fold opposite the tooth near the apex every 4 to 5 days for 3 weeks. The Kramer biofunctional regulatory test should be repeated to evaluate the results. If the degree of improvement isn't realized, the same series of injections can be repeated. It is permissible to have the patient take daily doses of the no-sodes and organ preparations during the interim. If the teeth to be operated on tested at D5 or D6 are to receive optimal therapy, they usually only require 1 injection prior to the appointment when the teeth are prepared for restoration. After the old restorative material is removed, as well as any base cements and decay, the preparation is cleansed with a dilute solution of hydrogen peroxide. A mixture of Sancombi, Mucokel, and Nigersan D5 is placed in a dish. This mixture, when applied to the tooth, will provide a formulation that increases the microcirculation in the pulp and stimulates the activity and number of cells involved in the immune response. Cotton pellet is saturated with a mixture, and the pellet is rubbed against all the dentin for at least 2 minutes. Then a low-level laser therapy unit is used for 2 additional minutes right on the preparation. This unit has a laser wavelength of 830 nanometers at 40 milliwatts. The energy will oxygenate the blood and increase microcirculation. If the tooth didn't have regulatory rigidity, one could proceed with the usual preparation and restorative procedures. If the tooth shows rigidity, it is temporized. If a base cement filling is to be used, a wet cotton pellet of the Sancombi mixture is sealed in the tooth under the base cement temporarily, If an acrylic provisional is used, part of the acrylic can be removed and the wet cotton pellets placed on the dentin in several places, and the provisional cemented with a suitable cement. Prior to the cementation, a cotton pellet saturated with myrrh from Walla is rubbed on the dentin for 30 seconds. Its action as an internal antiseptic acting on the lymphatic system reduces discomfort. Upon completion of the appointment, the homeopathic formulation from the multi-dose mixed injection vial is injected into the mucobuccal fold and the oral acupuncture points relating to tooth or teeth treated. Approximately 1/2 cc is used for each tooth. In the case of the teeth with regulation rigidity, especially if they have had readings of D3 or 2 vials of D3, they should be injected every 4 or 5 days for an additional 2 or 3 weeks after the operative appointment. EAP evaluation should follow a month later to assess the anticipated improvement. Once the Kramer readings have improved to 1 vial of D4, restorative procedures may proceed, and the likelihood of having pulpomesenchymal tissues that are much healthier. At the repreparation appointment for the long-term restorations, the above-mentioned procedures are followed in the same manner as teeth without regulatory rigidity. After completion of the preparation, whether it is to be for interim therapy or after regular preparation, many times we also inject a mixture of 1 vial of Traumheal, 1 of Silesia compost from Walla, 1 of Sancombi from Sanum, and 1 of Perfect Keel from Sonum into the mucobuccal fold after treatment on the tooth has been completed. Prior to this injection, 1 vial each of Sonums from Sonum, Xyloneural, a lidocaine neural therapy solution are injected in the same area. We try to do this at least 10 minutes prior to the injection in order to repolarize the tissues and return the acidic pH to a more optimal alkaline level so that the mixture will be more effective. The above mixture is used in addition to the mixed injection. It acts like a booster dose. If a patient is going to have root canal treated teeth or other teeth which have been determined to be a focus or field of disturbance removed, as well as cavitations and residual osteitis operated, it is very important to have a thorough understanding of the overall regulatory ability of the patient's basic regulation system. The probiotic medical physician and dental physician should not be satisfied with using only accepted laboratory tests such as SMAC, complete blood count, white blood cell differential immune panel to derive a diagnosis when a seriously compromised patient is to be treated with dental oral surgery. These tests do not accurately gauge the patient's usual and customary current physiological or pathological status or give information about the nature of the functional immune responses. Functional tests are needed to demonstrate good health or the progress of disease. I like to have the medical physician run either or both the bioelectric Vincent and the functional leukocyte test. Professor Vincent of France and agronomists developed the BEV test to measure the condition of the terrain or cell milieu of the body using saliva, blood, and urine, and evaluating the pH, the redox potential, and resistance. Professor Pitchinger and Kellner from the Vienna team proved that the basic regulation system controls the basic function of life. Professor Bergsman additionally discovered that both sides of the patient's body do not necessarily respond identically when tested or react in the same way when surgery is done. The response was affected by the degree of focus or field of disturbance existing at the time of the test or operation. For Pitchinger, a focus meant chronically altered tissue area which causes remote disturbances of the general and local kind. Scheidt used the term disturbance field where a region is disturbed, but since the word is ambivalent and it does not distinguish between a field which is disturbed and one that causes a disturbance. Hunicke therefore used the term interference field to mean where a pathologically changed tissue produces a disturbance via the nerves when it causes a remotely located disease. Some people prefer Peter Dosch's definition, summarized as an interference field or focus produces a change in the cell environment and hence in the reactive capacity of individual organs and of the organism as a whole. Where there is a hereditary or acquired organic predisposition, this can result in illness due to an interference field or focus. We should be indebted to these gentlemen for giving us the proper parameters and for developing approximate and meaningful methods. When a surgery is initiated, the first reaction of the body is parasympathetic responses and follows with a leukocytosis. In this phase, leukocytes begin to perish. This results in lymphokinin production, which calls forth a reversing effect in the body. Consequently, the reaction turns from parasympathetic to sympathetic lymphatic. Hans Selye used the label, the process is shock and countershock phase. These switchover processes in the basic tissues with the humoral, hormonal, neural, and cellular poles as parameters were made visible with the development of the leukocyte test. This test allows one to recognize the regulation sequence and define it if the surgery ought to be done now and or what special preparations are required beforehand. On a patient in the morning, on an empty stomach, 2 cc's of blood are withdrawn from both the right and left antecubital vein. Then 1/2 cc of Elpamed is injected back into the antecubital vein, right and left. A leukocyte count is done on the withdrawn blood. Right and left arm count is done separately. The needle prick causes the parasympathetic reaction. The Elpamed, on the other hand, activates the entire defense system. In other words, anti-shock phase is initiated. Then this is a switchover from shock phase to countershock phase. Elpamed, also known as factor M, is a long-chain, triple-conjugated, unsaturated fatty acid derivative made from the serum of stressed racehorses. After 1 hour, blood is withdrawn from the right and left earlobe. Another count is done. This is R1 reaction value. After waiting an additional 2 hours, blood is taken from the right and left finger tip using the ring finger. Another count is done. This is called R3, 3 hours after the Elpamed injection. Bergsman discovered that the focus process can proceed unilaterally and is side concordant. This means that the blood profiles of the two sides can diverge greatly. From this, one can ascertain which side of the body carries the burden. Another helpful test is the BEV. This test enables one to look at the biological age of the patient so one can compare it with the patient's chronological age. Value known as the energy point, if it is below 0.55, is indicative of an active focus or disturbance. Saliva, blood, and urine are evaluated in terms of pH, redox potential, and resistance. Excretion ability of the kidney can be determined and the ability of the ground system to detoxify as well. It's an overall excellent parameter of the condition of the ground substance or terrain. In a normal response, the white blood cell count has a starting value of 5,500 plus or minus 500. In response to needle prick and the injection of Elpamed, the white blood cell count rises to approximately 10 or 15% to about 6,000 to 6,500. In the ensuing 2 hours of countershock phase, it will drop back to the beginning value. Variances of 300 to 500 are meaningless. We would expect good wound healing when this patient undergoes oral surgery and focus elimination. The following typical products, both American and German, are started at least 5 days prior to surgery and continue for 2 to 3 weeks after. Lymphohepat, liver support, LMV drainage, BioE, Toxic Cleanse drainage, BLKI from BioE, Body Mend from BioE, Bone from BHI, Salacia Comp from Walla, Traumeel from Heal, vitamins A, C, E, and calcium, magnesium, zinc, and potassium. Once the surgery is completed and the wound is sutured saliva tight, the following remedies are injected into the surgery site. Sonuvis from Sonum, Nigersan from Sonum, Eucochil from Sonum, Traumheal from Heal, organ preps, maxilla and mandible, bone marrow from Walla, DNA from Staufen, RNA from Staufen. Now, low-level laser therapy unit is dispensed for home use. Return next day after injection. Use anesthetic and sauna 15 minutes before the other vials are injected. In delayed shock phase, the value only rises in the counter shock phase and remains in the shock phase nearly unchanged. In delayed counter shock phase, the reaction is much like the normal response, except the 3-hour value does not return to the starting value, which is rather normal to begin with, but stays elevated. This means it's an obvious focus load. Check to see if it's on the right or left side. Pre-treatment EAP and BFD testing results need to be evaluated to determine the dominant focus, whether the jaw segment has the largest, which jaw segment has the largest osteitis. This patient must be properly prepared before one inaugurates focus cleansing in order to minimize disturbances and healing. As with a normal response, the same remedies are used, but in this case are used a few weeks prior to surgery rather than a few days. Additionally, no-sodes, immunostimulation formulations, as well as colloidal suspensions of microorganisms are used. If there are multiple areas of disturbance or focus fields, you must first determine which is the dominant focus. Neural therapy, Vega, and EAP testing are all valuable techniques used to determine these hidden infections. There's a group of colloids gathered from the serum or blood of animals which have been injected with specific pathogens or their toxins in the biological structure of the metabolic happening. These are polysands, and they're directed to the organ of disease and only indirectly to the symptoms. These colloids are specifically charged, produced under sterile conditions, raised to the 9th power of dispersion. They contain antitoxins and lysins. Latter have the capacity of loosening the surface of the bacteria and opening them up for the antitoxins. They are non-poisonous and non-damaging because of special heat treatment, but are nonetheless in a position to create immunity. The means of application by rubbing onto the skin, their non-poisonous nature and the high dilution percentages makes them basically different from other kinds of vaccines and serums. Antigens stimulate the body to form its own antibodies, thus equates to an active immunization. They also bring to the patient already existing antibodies through their immune components. Thus, one can also speak of a passive immunization. Electrodermal screening along with agglutination tests on a microscopic level are acceptable methods of selecting the useful colloids. Those who have a microscope find them very useful in the selection of the proper colloids. Polysand K is essentially useful when there is a regulatory rigidity. It is a polychest character and has proven excellent as a basic therapy for treating chronic illnesses. Contains a strong stimulus towards creating antibodies is particularly good in circulatory disturbances and allergic illnesses. It is used as the formulation of choice for unblocking ground system rigidity when the functional leukocyte test determines that the patient has altered shock and countershock phases that would alter wound healing. The formulation is not used until the results of the Springler sand test are performed, especially the ones for polysand D and DX, which you use to define or locate the present of focus. 1 milliliter contains antigens raised to the 9th power derived from Streptococcus, lanceolatus, Staphylococcus aureus, Diplococcus pneumoniae, and antitoxins D9 created from the above-named strains. Rub 5 to 10 drops 2 to 3 times daily into either the inside of the elbows, thighs, or around the skin of the stomach. If the patient is very rigid, begin slowly by using 5 drops once a day, then work up the dose. The majority of patients will show an increase of T lymphocytes and T auxiliary cells within 2 hours of the application. After the patient's been on this remedy for approximately 2 to 3 weeks, the remedy should be tested with the EAP unit and a polysand test performed. After the latter, a drop of the patient's blood is mixed with a drop of polysand K on a glass slide. After 5 minutes, observe the slide. If agglutination of the mixture is present, determine if it is improved over the initial results or if the results are the same. One must see the improvement before one considers a surgical approach. 3X is very high in coarse accumulation, is a strong agglutination process, and a high antibody titer. 2X is equals coarse to medium accumulation, means medium antibody titer. Fine accumulation, fine lumping means a weak agglutination process and a weak antibody titer. And of course, some patients show no agglutination. One can begin focal therapy with sanitization procedures when there is a weak antibody titer and expect a good healing response. Thus, the patient with delayed shock phase reaction or the delayed counter shock reaction can begin a successful treatment. The big problem in diagnosis and treatment of chronic osteitis is the ability to locate the focus infection interference field. Traditional approach is taught by school medicine by visual inspection, radiographs, patient complaints, and palpation. If the teeth are presented, a talc tester can be used. However, if a tooth gives a normal reading and the x-ray does not show a break in the lamina dura, it does not rule out the presence of an early periradicular lesion. Radiographic evidence lags behind the actual degree of tissue destruction. It's been estimated at least 30 to 60% loss of minerals from bone is needed to make the lesion become visible on the radiograph. Supporting bone that surrounds the alveolar proper of the tooth socket contains the facial and lingual cortical plates of bone and the tuberculae between. The literature indicates that if a bony lesion does not encroach on the junction between the cortical bone and the cancellous tubercular bone, it will not be visible on the radiograph. Thus, it is often difficult to find these lesions. However, Dr. Carl Springer developed two springal sands or polysands that are most helpful in testing for localized infection in teeth or alveolar bone in the absence of teeth. Chronic foci in the area of the sinuses, teeth, and tonsils may not have obvious clinical symptoms but are manifested by general symptoms such as depression, headaches, moodiness, tiredness. He developed these formulations, Polysan D and DX, as focal diagnostic aids. Polysan D is antigens raised to 9th power developed from Streptococcus hemolyticus, lacticus, pyrogens, and viridans, and Staphylococcus albus aureus, and pharyngitis, and Diplococcus lanceolatus, Microbacterium tuberculosis, typhus bovinus. Areas of use: testing of all localized infections, teeth, tonsils, sinus, gallbladder, appendix, prostate gland, adnex areas. Schedule the patient for the first appointment of the day. The patient must not use any analgesic medicines, either allopathic or biological, for at least 12 hours. They should not wear any jewelry on hands, fingers, necks, or ears. Before any remedies are rubbed in, a manual examination should be done, checking for pressure sensitivity of the teeth and any edonculous spaces. If areas of sensitivity exist, they should be noted. Have the patient rub a total of 20 drops. Sometimes a total of 40 drops are used at once, of which 5 drops, a drop at a time, are vigorously rubbed on both the right and left side of the neck below the angle of the mandible into the anterior cervical chain of lymph nodes and into delicate skin areas on the inside elbow bend. The elbow areas of vessels lie near the surface, and the area is transversed by the lymph meridian. It originates at the outer thumbnail corner and moves along the ball of the thumb. Colloidal material will be deposited over the reflex areas of the lymph organs and the lymph meridian of the opposite body side through the thumb ball of the rubbing hand. The rubbing should be done vigorously until the skin turns red. Sources of infection will be revealed through pain and sensitivity. An infected tooth or teeth will begin to ache and become sensitive to touch, heat, and cold. The odonculus area will become painful. Tonsils react with signs of beginning infection. If sinuses are infected, a typical pressure feeling or tugging like pain will appear. The gallbladder, appendix, prostate gland will become painful if there's a chronic infection that was subclinical. Sometimes the pain will appear in 2 to 3 hours, while other times it may take up to 8 hours. Occasionally it may take more than 24 hours. The patient must be told what to expect, be able to grade out the pain responses on a scale of 1 to 10 as to what the observed reactions were, their precise location, duration, and strength before they forget. Patients told to rub the areas in his or her mouth around the teeth and spaces, as well as the sinuses, the appendix areas, at the end of the day and in the evening if the pain didn't jump up at them. Any intensification is a positive sign of a focus. The patient is advised to note all body sensations, even if they last but for a few seconds. It is advisable for the patient to do a self-examination process the next day as well. Some doctors prefer the patient to come back to the office for a repeat of the manual examination at the end of the first day or the next morning. The sophistication of the patient is of prime importance in the scheduling process. If there is no reaction or a very vague one, the test should be repeated a few days later. If there is once again no reaction or only a vague response, one can consider that there is the absence of an infection. On the other hand, if a test is positive, the test should be repeated for confirmation. A few days later, Polysan D should be used in a similar fashion as explained with Polysan. Polysan D is composition is antigens raised to 9th power developing Streptococcus, Lanoletus, Staphylococcus aureus, Diplococcus pneumonia, and antitoxin DC created from the above named strains. Like Polysan colloidal D, Polysan colloidal DX serves as a diagnostic tool to determine the cause and location of the infection. If neither of these two can localize an infection, Polysan K can be used in the same manner. Correctly performed, these tests should be done during the patient's initial workup rather than when treatment is well underway. This presents the case from being camouflaged as to what the focus picture really is, enables one to treat more successfully. It has been found that Polysan D and DX can also be used for therapeutics. Results of tests show a connection between the precutaneous application of these highly diluted forms and cellular activity. The point towards an immune modulating effect of the preparations. Positive remedy, Polysan D or DX, is rubbed into the elbow or neck as previously discussed. I prefer the neck area because of the locality of the disturbance. Rub 10 drops on each side twice a day, morning and evening. The second week, increase dosage to 20 drops each time. 1 tablet of Notakil is swallowed each day. If the focus blows and the pain ensues, the Notakil is increased to 3 a day. The tablet is first put over the area of pain for 30 minutes and then remains swallowed. Suppositories or ampules can be used depending upon the dentist and patient's choice. The Notakil is used for at least 3 days after the pain subsides. Once a week, an ampule of Butylin S strong is injected deep into a muscle in the buttocks area for 4 to 6 weeks. Notakil is injected once a week into the focal site as well for 4 to 6 weeks. It is very important to use drainage remedies for the lymph system as well as for the bladder, liver, and kidney meridians so that toxins can be effectively removed. Charcoal capsules will aid in the bowel detox. If there are focated teeth, then it is well advised that they be removed using traditional oral surgical methods. Mixed injections of the following formulation negate the use of painkillers and tremendously enhance the healing response. 1 vial each of Sanyavis from Sonum, Muscoquil from Sonum, Nigrosan from Sonum, Traumheal from Heal, Osteitis noso D3 from Staufen, Organ Prep, Maxillae or mandible and bone marrow compost, D3 to D200 from Walla. In this preparation, I shared with you the techniques and protocols used in the treatment of teeth that may be subjected to a variety of restorative procedures. The dental handpiece with its turbulence and swirling high and low pressure areas that are created inflict undue trauma to a tooth. This initiates a multi-complex cascade of inflammatory activity in the pulpal and periapical mesenchymal complex. If this complex exists in a chronic degenerative inflammatory condition, it can exert a negative influence on the basic regulative system of the body and thus influence homeostasis, diminishing the quality of life for the patient. If a patient is going to have surgery, I've illustrated how the functional immune system can be measured, and if it is regulated as well or is in a state of rigidity, methods were given to unblock the rigidity so the adequate healing could take place with a minimum discomfort to the patient. I hope you understood that better than I did. That's it.
Bill, for those of us who are into this, can we get a copy of this?
You have to yell at me, Dietrich. I'm deaf.
Yeah. Can we have a copy of this paper?
Not from me. I'll see if I can get you a copy from the author. I have it in confidence and have to return it. I'll see if I can get him to give you one. I'll ask him to. Who does this? I'm gonna leave it up here.
He has to come up here and get something. George? I'll come up here and get this. And introduce you as he's putting that on.
Here, let me check this in here.
It's a pleasure to introduce the next speaker, George Meinig.
Is that okay?
If you haven't bought this book, you ought to, and you ought to buy more than one copy. I bought a dozen off of him, and I've been passing them out, issuing them out of our library in our office. It's a beautiful done book, and it's something that is a real compliment to this individual who has worked very hard on this. He has a beautiful foreword in here to know about his life history and how he got involved in this. And I encourage you to purchase this book and know this fine gentleman, because I have the Weston Price book that Huggins did, and I have this one here, and I can tell you our patients are loving this one a whole lot better. The introductions that you've done, the first 2-3 chapters in there, are very well presented. So I thank you very much for this outstanding endeavor of dentistry for us.
Thank you very much.
A lot of us dentists, and you're certainly going to help a lot of our patients. Thank you.
Appreciate that. On your feet. On your feet. After the lunch thing has got you all drowsy. I want to wake you up a little bit. While you're doing that, I'm going to show you a TMJ deal. Any of you know the Diamond Gate business?
Oh, yeah.
Okay. Do you know the TMJ one from John Diamond?
No.
When you go this way, your chin sticks out this way. When you go this way, your chin sticks out the other way, and you look straight ahead at a point. The reason I'm doing that, it straightens out the meridians from the two halves of the brain, and so I'm hoping I get a little straightened out here before we start.
You guys got too much mercury in that brain. Get the mercury out first.
That's supposed to straighten out the TMJ. Now, time I learned that, I had retired from practice, and so I did a lot of TMJ, but I don't run into too many cases, so I don't get a chance to push that. So I don't know whether it works or doesn't, but John Diamond said it works beautifully. So anyway, for whatever it's worth, meeting so many of you astute professionals has been a thrilling experience. Your enthusiasm and interest in the biological aspects of practice is a real joy to behold. Not only that, but the enthusiastic welcome I've received from so many of you has really warmed my heart. You will never know how great it is for an author to receive such an open acceptance of his work. For the fact that so many of you have my book, I must thank Ed Arana back there. He has gone all out to introduce it to you and to the group at the other groups in amalgam-free dentistry and the numbers of other people around the country. And so the sales have been going great, at least with these groups. We still got to hit the general public hard, and we're working at that. About my book, when I decided that this book must be written, I felt it would be better if I directed it to instead of to our profession, to the lay public. I was afraid if I directed it to the profession, they would accept it but say, yeah, this is great, but we need more research, and it would be buried again for 20 or 30 or 40 years. So I decided the best way to do it was to direct this to the public and hope that they carry the message to their doctors and their dentists so that we know what's going on. It helps some for me to have experience in putting technical terms into lay language. A book like this must use technical names of things, and that's a little disturbing to people. But I've tried to limit most of the technical names to that sort of thing, and you can't avoid it. But I've tried to keep the other technical names out of it as much as possible. People generally, and many of you here have expressed the feeling that I did a reasonable job of keeping it readable for people, and generally I hear that story from many, so it's gratifying. This all started because my dear mother, when I got out of dental school, said, hey, George, now don't go around using all those big highfalutin words in front of your patients, you know, that you doctors use all the time. Put it in good language for them. And she kept after me with that, so much so that I, through my practice, kept trying to word things in a way that people would understand. And that kind of rubbed off, and eventually I became a columnist for our local paper, and for 17 years had a column called Nutritionally Speaking, where I answered questions on nutrition. And this was a real challenge to keep that up and to talk in lay language to people. And so when this came along, it gave me a chance to further use Price's work in a way that I hope people would understand. Now, this book of mine, it's all about a 70-year cover-up of one of the greatest medical discoveries of all time. And I mean that, of all time. Buried along with this outstanding research is the astounding fact that a very high percentage of chronic degenerative diseases that are epidemic in our country today come from a single cause: root canal filled teeth. Think about that. It took me a while, in being with this for a long time, to really realize that that is a true paragraph. Though the source of these infections is dental in origin, the serious side effects that take place are mostly medical diseases. When bacteria infect root canals, they also become trapped within the very structure of teeth. Then, much like cancer cells that metastasize and create cancer in other areas, these tooth organisms can and do escape, and they escape into the blood supply. They too metastasize, and as they migrate around the body, they set up new infections in people's hearts, in their stomachs, in their kidneys, in their body joints, in their eyes, in their brains. And it's come up here several times. You know how close our teeth are to that brain and the blood supply and the nerve supply. We don't think of that too often, even as dentists, but there's a very close connection. Anyway, to people's kidneys, body, joints, eyes, brains, to pregnant women, and in fact, to any organ, gland, or tissue. This is a bigger problem than anyone can imagine. 24 million root canal cases were treated last year, and the total number in existence is astronomical. This book is really about thousands of animal and human studies that were made during a 25-year research program that authenticated how severely these infections impair people's immune systems. Physicians and dentists believe these focal infections can be cured by antibiotics. They cannot. They cannot, because antibiotics can't get into the parts of the teeth that hide these bacteria. In the mid-1920s, a vocal minority of autocratic doctors who disbelieved in the focal infection theory were able to cover up these crucial findings, cover them up so well that hardly a dentist and a physician in this country today knows anything about the existence of this entity. In the mid-1920s, I mentioned that. These significant discoveries were made during a 25-year extensive and meticulous research program by Dr. Weston A. Price and his team of 60 of the nation's leading scientists. They're important experiments. Now get this, these important experiments were conducted, the last 10 years of them, under the auspices of the American Dental Association. It's hard to believe, isn't it? and its research institute. That's a story in itself, but they did have this, and this is the way it was conducted. It is high time Price's contributions to humanity are recognized, and the millions of illnesses that now exist because of root canals are corrected. Dentists seemingly are quite successful in doing root canal therapy. and for the most part, these teeth remain comfortable for many years. You, the public, and the professions as well, are going to learn for the first time that no matter how good these teeth appear, they always remain infected. Let me tell you a little bit about this man, Dr. Price, and his 25-year root canal research program. It is of interest to learn that he was a dental research specialist. He spent half of his time in a busy practice and the other half doing dental research. And for this, he accepted no pay. And for this, he gave much of the equipment that went into the laboratory. His work resulted in 220 articles that appear in the dental literature. He also demonstrated a great ability in selecting and directing his team of outstanding scientists. Dr. Price was called by many the world's greatest dentist. He was doing root canals back in the early 1900s that were every bit as good as any we see today. In spite of his success with this treatment, he became suspicious that these teeth always remained infected, and it was that suspicion that led to what proved to be the most exciting discovery of the many that were produced during his 25 years of research. Price had a patient who had done a root canal for some 10 years before. This woman, by the time 4 years had elapsed, had developed a severe arthritis. She was so arthritic in her ankles, feet, and legs that she was wheelchair and bed bound. The only way she could get around is somebody pushed her in a wheelchair. Her hands were so crippled that she could hardly feed herself. And you'll see a picture of her on page 3 of the book, so you get an idea of what her status was. Well, Dr. Price had a little trouble convincing her that he thought that tooth might be her trouble and that she ought to have it removed. And he finally did, and by saying that he was going to do some experiments that would help to show her why this trouble occurred. So she came in that morning for the extraction, and the tooth was removed, and he dismissed the patient. And after he dismissed the patient, he washed the tooth, and then he bathed it in a disinfectant, and then he secured a laboratory animal, a rabbit, and he made put some anesthetic in the back of the rabbit, and he made a small incision, and he tucked the tooth under the skin of the rabbit. And he put the rabbit then back in its spacious cage that had plenty of good food, and 2 days later, lo and behold, that rabbit had the same arthritis in its limbs that patient had in hers. This was quite a shock. Not only that, the rabbit died 10 days later. So this kind of substantiated his theory and lent validity to his contention that these root-filled teeth continued to be infected. From then on, whenever Price had a patient who had been suffering for a long period of time with a degenerative disease, a disease that the medical profession was failing to treat successfully, those people who go from doctor to doctor and keep getting worse and worse. Like that arthritis patient that he found was most startling. What he did then was every time he got a patient that had a degenerative disease, he felt that this had some connection. And so if they also had root canal fillings in their mouth, he advised them to have them removed. And the same procedure went on. He buried the tooth under the skin of a rabbit. And what happened was, in almost every instance, the rabbit got the same disease that the patient had. Once in a while it didn't get the same disease, but it usually got one similar. Like if a rabbit had kidney trouble, maybe the rabbit got a bladder infection, but generally that was the same disease, which is a pretty startling fact when you get to thinking about it. Well, in order to understand all of this, and when we're talking to lay people, we have to get to the basis of things. And what I've told you is reasonably understandable, but many people say to me, what's a root canal? And most of us are so close to it, we don't really think about the fact that maybe they don't know what a root canal is. And so we have to kind of describe that situation. And I won't go into that part of it, but what I do tell them, or the ones I talk to, is I say when a tooth has a big cavity in it and it finally gets into the nerve, and that always shook me up a little bit when the patient said the nerve and not the pulp, but maybe it shakes you up a little too. But that's the way people talk to us, and so I got in the habit of saying the nerve, and even though it shook me a little bit. This treatment procedure involves the removal of a nerve. I'm telling this to the patient. This treatment procedure involves the removal of the nerve, disinfecting the area, and then filling the root canal. In view of the fact that the root canal treatment seems to be so successful that even large areas of bone loss heal up, why then do they become infected? For the answer to this, it's necessary to look at the structure of a tooth. And so we have to describe to the patient a little bit about what the tooth is all about. And so the way I tell them is I say, you know that the enamel is a thin layer over the crown of a tooth. Well, just below that enamel is the dentin of the tooth. Now the dentin makes up about 80 to 90% of the tooth substance. And it's a very hard substance. You can tell that when the dentist drills your tooth because of the way it feels to you. You will find that its hardness is difficult to understand when I tell you it is not a solid substance at all, but it is made up of tiny, tiny tubules. These dentin tubules carry a fluid, and that fluid contains all kinds of nutriments that keep teeth alive and healthy. These dentin tubules are so tiny that 20 to 30,000 of them will fit into less than a 1/16 of an inch. Normally we'd say a millimeter, but 1/16 of an inch is more something people can understand. If we take the tubules of one of our smallest front teeth and line them up end to end, they will stretch 3 miles in length. In other words, they'll hold 1/2 of a lot of bacteria, billions of them. When a cavity gets too big and exposes the nerve of the tooth, the bacteria also get into these tubules, the billions of them. Dentists have felt their sterilizing of the root canal and the presence of the root canal filling really kills off these bacteria. Well, they don't, and neither do antibiotics because they can't get into those tubules, because the tooth loses its blood supply when the root canal is filled. The question is, why don't they die off? It's because they are polymorphic. That is a technical term that means they mutate, that they can adjust to severe conditions, that they can change their form. The little buggers get very angry and readily adapt to the most severe adverse circumstances. Those that need oxygen to live learn to exist without it. Because nutriments in the dentin tubules have decreased and are no longer provided, the germs become smaller. They become more virulent, and their toxins become more toxic. Though you might think that they are trapped by the root canal and can't get out, don't believe it, they can escape. They do this through the lateral accessory canals that are present in all teeth. Not only that, but their toxins go right through the root's protective cementum covering and the surrounding bony network. You see, Dr. Price found the cementum is a semi-permeable membrane. That means that things can't get through it, things materially, but liquids can. Interestingly, the Dr. Price team of researchers did experiments that showed the toxins were more dangerous than the bacteria themselves. About these bacteria, they start out in the beginning as friendly bacteria, as all of you so well know. In the Dr. Price's time, however, it was believed that there were about 100 varieties in the mouth, and that they all live at peace with us. It is when they become trapped in teeth or gums that they become menacing. Today, there are some 350 that have been identified that live in the mouth, and I learned that in May at the American Association of Endodontic meeting by a bacteriologist from the University of at Portland, Oregon. The most frequent found Among the scientists on the Dr. Price's team were some outstanding bacteriologists. They found the vast majority of these focal infections were caused by Streptococcus bacteria. They identified the many different kinds and also what diseases resulted from each specific family. Though Streptococcus predominated 90% of the time, Staphylococcus and spirochetes are also involved, as are amoeba. The most frequently found Streptococcus were of the Fecalis family. Though these studies were done during World War I days in the early 1920s, recent bacteriologists have also reported the Fecalis family to be one of the ones most often found in dental infections. And so this really substantiates what Price did so many years ago. The cause of these mouth infections, as I said, is substantiated. My book has a chart showing the 10 varieties of Streptococcus that the Price group found caused these degenerative diseases. Price and his bacteriologists not only listed the bacteria, but the frequency with which they caused specific diseases. And to me, that was pretty startling to see them list various types of diseases and how many times certain bacteria caused those diseases. And the Streptococcus faecalis was involved 65% of the time. The others in diminishing amounts. Now you might just think that I have some vendetta or some grudge against root canal therapy. Nothing could be further from the truth. In fact, I was one of the 19 dentists that started the Root Canal Association 50 years ago. And the association had its 50th anniversary in May in Chicago, and I was an attendant, as did my brother, who was one of them, and 2 others. There are 6 of us alive yet out of the 19. And the whole meeting was based upon honoring those of us that started that association. Well, my book was getting ready to get to the printer, and I didn't mention a word about it, as you would imagine. It would have been a little hard to explain orally. I thought it'd be better to have them see it. I was also a member of the Dr. Edgar Coolidge Root Canal Study Group. I don't know how many people are aware of him, but he was a professor at my school, unfortunately, and for me, and he was the leading man in root canal therapy at that time. And through that, I became a member of his root canal study group. We were appalled at the wholesale extractions that were going on in those days. Very few men were doing any root canals, and extraction was the rule. We couldn't figure out how a dentist could learn how to save teeth by extracting them. And that was our theme song when somebody challenged us a bit, which they did very often when we gave seminars all around the Middle West. So I was partly responsible for starting this. The Endo Association now has 4,000 members. It was really started to teach the general dentist how to do endo, but after it got started, the specialists realized that they needed an organization, and they glommed on, so it's really a specialist organization now. And I didn't limit to endo. I did general practice, but did a lot of endo in my practice. Our hope today is that future research will show a way to sterilize the bacteria that are hidden in those dentin tubules. And I've been hearing a couple of ideas here since I've been at this meeting that sound very encouraging, whereas when I came, I wasn't sure that that was ever even going to be thought of it being possible. Some dentists actually contend that because their root-filled tooth is a dead tooth, it's a foreign body and antigens will be produced and other things, and that it's just going to be impossible to solve the infection problem. But I've heard some very interesting things, and I'm going to try and encourage some of these men make some reports to you about what they're doing. It's difficult to comprehend the depth and extent of all of the different divisions of the study of root canals that were covered during Price's 25-year research program. It is well for you to know that Dr. Price documented all of his team's accomplishments in 2 volumes. These 2 volumes contained 1,174 pages. The 2 books weigh 9 pounds. It's a real formidable study. In addition, there are 25 articles that he wrote that are in the dental and medical literature about root canals of the 220 he did altogether. It is hard for dentists to appreciate the great rapport and respect for which Price was held by the medical profession. A lot of his articles appeared in medical journals, as a matter of fact. Regarding his placing of teeth in rabbits, there are those that believe such action would always cause infection. Price wondered about that himself, so he secured 100 healthy teeth, teeth free from caries and free from gum disease. When he buried these under the skin of a rabbit, not a thing happened to the rabbits, as you might suspect. Those that were embedded lay there dormant. Some even exfoliated themselves out of the skin, and others dissolved away. He also embedded some sterilized coins and some pieces of glass just to see and prove that this wasn't a fluke, and that all these teeth he was planting with root canal teeth that were causing infections in everybody was not a thing that wasn't viable. I don't know how many of you were taught or are aware of the presence of bacteria in dentin tubules. That fact never came to my attention in the whole 47 years of my practice until I saw a picture of them in Price's two books, and they were published in 1923. I assume dental students today have seen electron microscope pictures of tubules and their bacteria contents, and you probably have too. And if you haven't, they're in my book because I was able to borrow some or have the permission from Dr. Bronson, a great investigator in Sweden. And I incidentally called Dr. Bronson in Sweden and asked for his permission to use some pictures. And after he said yes, I said, have you done any research about the bacteria that are in those tubules? He said, no, we haven't done anything like that. I said, do you know anybody who has? He said, no, I don't know anybody who has. It's pretty much a shame, isn't it? Some people wonder why Price embedded teeth under the skin of rabbits. Keep in mind, he didn't know where the infection was in the teeth when this all started. He just suspected that there was a problem. This procedure was really no different than that of culturing bacteria of an infected area, growing the bacteria and then injecting them back into an animal to see if you could produce the disease, and then test drugs to find out how good or efficacious they were in solving the problem. Price was eventually able to culture the bacteria present in tubules and grow them, reproducing the patient's illness by injecting it back into the animals. And he started out first by cutting the tooth into little pieces and just putting pieces under the skin of the rabbit, and the rabbit still got the same disease. And then he put it in powder, and he put a little of the powder in, and sometimes he injected the powder, and they still got the same diseases. He didn't have to have the whole tooth at all. It just happened anyway. For some time, they suspected that the bacteria produced toxins that contributed to the illnesses experienced by people and animals. Bacteria from these teeth were cultured, and then the bacteria was liquefied and centrifuged, and the bacteria were then filtered out from the liquid, and the remaining liquid containing the suspected toxins was then injected into some animals. The portion containing the bacteria alone was also injected into some other animals. And here again, lo and behold, the animals that got the toxin part of the division got much more serious illnesses and got them quicker than those that just got the bacteria. One heck of a study. To carry this further, Price sealed a small steel tube into a root canal of an apex of a tooth, and he pumped some colored dye solution into it. He found the solution went right through the tubules and through the roots, protective covering its cementum. However, when the bacteria were produced, they were too large to penetrate the cementum, and they did go through the lateral canals. This experiment showed how root canal bacteria and their toxins were transmitted to the periodontal ligament and the surrounding bony tooth socket and its blood supply. In a study of the disinfectants needed to treat root canal infections, Price studied over 100, and he studied them even in different dilutions. The ones they found and reported most efficient are still favorites today. There are a number of new ones that are being used, but none as yet have stood the test of time. Lasers are held to be the biggest hope, and we've found out a lot about that in these last couple of days. It is difficult for people and doctors as well to appreciate the complexity of these infections hidden in teeth. Most infectious diseases we are familiar with are caused by specific bacteria, and each one causes a very specific disease. These varieties that dwell continually in the mouth are friendly bacteria, but when they become trapped in the infective environment of our badly decayed tooth or abnormal gums, they live a Jekyll and Hyde existence. I mentioned earlier how these organisms mutate and become virile and their toxins more toxic. I'm going to pass over Price's extensive study of root canal filling materials, as the favorite then, gutta percha, is still considered the favorite today. The changes that were in other studies, changes in the blood were found to occur, and from these dental infections, and it's very interesting how many of those there were. For instance, most of the time a low white blood cell count, leukopenia occurred, deficiency of red blood cells, erythropenia, an increase of the number of white blood cells formed in lymph tissues, lymphocytosis. If I do this for lay audience, I like to tell them in lay language, but also tell them what the word is, so that they know there's a little technical data in back of this. And a tendency to hemorrhage, hemophilia. In addition, changes in the body content of ionic calcium takes place, and the pathologic quantities of calcium accumulate in the blood, and we've heard a number of people talk here today about the importance of calcium. That was one of the biggest things that Price covered. The alkaline reserve is lowered, acidosis occurred, there's an increase in blood sugar, uric acid is increased, nitrogen retention occurs, and the products of imperfect oxidation develop. There's a tendency to regard all of the diseases that occurred as being relatively few in number, but I think from just the mention of some of these things that I just did about the blood study, because the number of diseases is even more long, will tell you how extensive that program is. Time won't permit me to review all of the discoveries Price made, so we'll get on with a few other things. The day was getting long, as you know from what has happened here. As a 50-year member of the American Association of Endodontists, I was able to obtain a complete list of all of the literature pertaining to root canal therapy. Articles and books from that list appeared articles and books from that list that appeared to relate to Price's study I obtained from the ADA library. Actually, little information has been published that confronts the main issues of root canal infections, but my book does cover the numbers of studies that do this and are related to the Price research. What I'm saying is that the big issues of this research, there isn't any other information been presented. But for a lot of the side issues, there's a lot of research that's out there that does tie in, and you have to kind of pull it out of the literature in order to find it. I should take a few minutes to tell you about one that'll take your breath away, and that's a Dr. M.H. Fisher, an M.D., whose book, Death and Dentistry, was published in 1940. His work confirmed Price's 100%, and what he had to say will hit you like a heavyweight boxer's knockout punch to the jaw, because what he said is dentists in their addiction to the slogan, "Save the tooth," increasingly lose the patient. Now, Dr. Fisher goes on to say few dentists have any knowledge of the hidden side effects of root canal fillings, how they occur, and why they are responsible for an infinite variety of serious degenerative diseases that ravage our body. Needless to say, none of us have been fully aware of the connection between these occurrences and the number of people who die because of them. Generally, the average dentist in all of his years of practice is not aware of any patient dying as a result of his dental treatment or her dental treatment. Of all of my dental friends, I do not know of a single one who has knowingly lost a patient. Suddenly, as a result of these numerous studies by numbers of authorities, dentists must look at their role in instigating endocarditis, kidney disease, liver disease, and all those other possible focal infections. How many people are dying before their time because of the hidden polymorphic bacteria that are inhabiting root canals? Earlier, when I mentioned Price's research team consisting of 60 leading scientists, I should have mentioned the names of some of them, as they are important enough to know, and it's important enough for you to know that he had one deuce of a lot of support in the medical profession out there, and there was a lot of people working on the focal infection theory. There were such people as Dr. Charles Mayo, who started the Mayo Clinic, Victor Hechtholm, professor of pathology, University of Chicago, Milton Rosenau, preventive medicine professor, Harvard University, Frank Billings, who proposed the focal infection theory and who by 1914 had found that 98% of all focal infections came from teeth and from tonsils. Thomas Forsyth, who started the famous children's dental clinics in Boston, Massachusetts. Frank Lilly, professor of zoology and embryology. Truman Brophy, dean of the Chicago College of Dental Surgery, who was one of the dental educators who led dentistry out of its status as a trade to that of a highly recognized profession. Incidentally, Chicago College of Dental Surgery was my alma mater. I would be remiss not to mention that some critics will say Price's work was anecdotal, partly because his second book contains so many case histories. Dr. Price was very conscious that he might insert his own efforts into his own personal feelings into what he was doing. Double-blind studies, of course, had not been dreamed of at the time, but what Price did to substantiate his experiments was not to rest on any thing that he thought was a good success, but for example, when a root canal tooth of a patient having kidney failure was planted into a rabbit, that rabbit got kidney disease. And so when the rabbit died in about a week or 10 days, he took the tooth out of that rabbit and he washed it and he sterilized it and he replanted it in another rabbit. And that rabbit got kidney disease and died within a short period of time, and he took the tooth out of that rabbit and he washed it and he sterilized it and he put it under the skin of another rabbit. He repeated that 30 times, and each time the rabbit died of kidney disease. And as succeeding times went on, it became slightly slower, but it wasn't much slower than it was the first time. The vast majority of Price's discoveries were reported only after the work they did was repeated. In a lot of these experiments, they were repeated hundreds of times through that period. But even with that, let me conclude with Weston Price's own words as they so well portray his greatness and love of humanity. It is my interpretation of the preceding researches are correct. If my interpretations, are correct, there is need for a recasting of the fundamentals for diagnosis, prognosis, and treatment, and I am not unmindful of the tremendous responsibility that I am assuming in suggesting a new alignment of these fundamental principles. It has been because of a recognition of this tremendous responsibility that I have refrained from publishing these data until after I've had a chance to test them out, not on a few hundred, but on many hundreds of cases, and my presumption and my final willingness to do so are based entirely upon my personal confidence that they are correct. I do not assume that my interpretations are correct in every detail, as later information will indicate, but in light of present knowledge, they seem to me to be the most logical, and I feel it my duty to give them to humanity and to the professions in order that others may assist me in correcting and enlarging them as further facts may indicate. That's the end of the quote. Our first concern is about these matters is that almost everyone looks upon a tooth decay as a trivial matter. Consequently, there's not much anxiety by people or dentists over a tooth having a tiny cavity or a deep one. However, deep cavities do lead to the necessity for root canal treatment, which is, as you have seen, a very serious matter and certainly not a trifling one. Though almost everyone is aware that sugar is a factor in tooth decay, very little limiting of sweets is being done by people today in this country. Dr. Ralph Steinman's research demonstrated how dentin tubules contain a fluid, and that fluid has movement from the pulp into the every portion of the tooth. How this fluid contains nutrients that keeps the tooth alive and healthy. Even more importantly, he showed how when sucrose was injected into the animal, into its abdomen, the fluid flow in the dentin tubules was actually reversed. And when that happened, caries took place promptly without the sugar ever touching the tooth. Well, why do we keep looking at dental caries as a disease that affects only our teeth when actually it is a disease that affects every cell of our body? Dentists are exceptionally talented in restoring decayed teeth, but we and our physician colleagues are at a loss in understanding the systemic degenerative diseases that rest on the rest of our body. They want me to knock it off here. I was trying to find an interesting place. I want to thank Ed Arana again for his introduction of my book to many of you and for your kind attention here today. There are a few things that should be said, and maybe somewhere along the line you can ask me what they are. There's some ways I think that must be said, and that is that you can very easily get into trouble advising somebody to have a root-filled tooth out because it's a root-filled tooth. Now, you should be sure that if you do this, that you inform the patient that it's very likely that their degenerative problem is due to the root fill, but it may not be. That their disease might be caused by another bacteria, by another organism, by a parasite, by nutritional inadequacies or excesses. Any number of things can be causing these things. However, what you can assure them and can emphasize is that having this root canal is going to allow bacteria to be pouring out of those accessory canals and toxins through the cementum of the tooth into their bloodstream continually, and that's not doing their immune system any good. So that if they're trying to cure something, even if it isn't the cause isn't the root canal filling itself, it's not going to do them any good to have that root canal filled tooth in their mouth. It's harming them. So I think you ought to protect yourself along that way, because otherwise somebody's going to have arthritis and have their tooth out and say, my God, it didn't get better, so I'm going to sue you for it. And I think you better remember to do that in every case. Yes, sir.
Two questions. Number one, what was going through your mind at the banquet last May when you had the book almost completed?
I'm sorry, I'm not hearing you.
And you knew you were going to, when you knew what you'd written about the book,
Yes.
about how these people would take that, what was going through your mind at that banquet when they're giving you kudos and congratulating you for being one of
It was racing in every direction you can imagine. I felt highly honored that the president conducted the whole meeting. The whole 5-day meeting was based upon honoring us for starting the Root Canals Association, and you know, that's pretty hard. You know, your ego gets pretty inflated with that kind of thing.
Did they call up and ask about the book after you signed those 10 copies?
No, I have not heard a word except for one thing. Very interestingly, a month or so ago, a month and a half ago, I got an order and a check for 10 books from the American Association of Endodontists. No explanation, just an order and payment. And my wife said, "What's that all about?" And I said, "Well, I can guess. Somebody's complained and said, what the hell is this all about?" And they have bought a book for every board member, and every board member is reading it. My brother, who is also one of the founding members, said, "George, the worst thing that's going to happen to you is that they say nothing. The best thing that'll happen is that there's controversy, because then you'll sell books. Then the public will know more about it." Anyway, thank you a million. It's been great to be here.
Good job. Thank you.
We'll take a break and be back at 4:45 for Jess
All right.
Clifford. He'll need
Wasn't too
an hour
simple.
and 45 minutes for his material, which will take us to 6:30, and then 2 people have about 5 minutes of needs, Dr. Klinkhart, Dr. Schuhart.